Hi, I'm Meryl. I'm one of the students in the Trends and Issues nursing course, and the topic that I want to discuss today is the Death with Dignity Act. And I feel that this is a nursing issue as far as ethical topics because we see so many patients in palliative care situations. And in light of the young woman, Brittany Maynard, who recently passed away, who had moved to Oregon in order to participate in the Death with Dignity Act, it's much more a topic, at least with the patients that I see in hospice, it comes up more often than I would have thought. So, the first thing that I will talk about is the focus of the law is to protect a mentally competent, terminally ill patient as they make their decision to hasten their own death when it becomes imminent. To protect a terminally ill patient who doesn't want the choice or who is not competent or capable of making that decision, and to protect from prosecution any physician who writes the prescriptions within the guidelines of the law. To protect from prosecution any physician who does not want to write the prescription, and to protect from prosecution any pharmacy who does fill that, or any pharmacy who refuses to fill that prescription. It also would protect any hospital or other organization that does not want to participate or doesn't want their employees or physicians to participate, and to legally clarify that the death of a qualified terminally ill patient under the guidelines of the law is not a murder, is not manslaughter or assisted suicide. Therefore, it protects the family members, any witnesses to the death, care providers, and their organizations from prosecution under the laws. So that's the goal and the guidelines of the Death by Dignity Act. Oregon is one of the states that does have that act in place, as well as Washington, California, and Vermont. Montana kind of has an interesting setup. They had tried to pass it in their legislature sessions a few different times, I think 3 actually, but as it's turned out, what guides that process is in December of 2009, there was a Supreme Court ruling in Baxter versus Montana that nothing within their current state laws prohibited a physician from honoring a terminally ill, mentally competent patient's request by prescribing medication to hasten their death. The ruling cited the state's Rights of Terminally Ill Act because there was such a little difference as a matter of public policy between taking a patient off of life support and prescribing lethal medication that the patient could take. The court determined that existing Montana law permits physician assistant dying under the circumstances of the Baxter case. Now, I'm not going to go into what the Baxter case specifics were, but this article will be posted, or the link of the Death to Dignity, and you can look at Montana in particular to come up with a little bit more information that's detailed about that. But it's a very strict guideline that's set up, and I'll get to that in a minute. But for your curiosity, in January of 2015, excuse me, Representative Steve Copeland, who is a Democrat from Beggs, introduced House Bill 1673, the Oklahoma Death with Dignity Act. The bill was referred to the Public Health Committee, and it did not make it out of that health committee. The 2015 session was the first time a death by dignity or a death with dignity bill was considered in the Oklahoma legislature, which I thought was interesting. But you could look up, again, this link will be included, and you can look up the full text of the House Bill 1673 and see what the Oklahoma legislators were looking at, just for your curiosity. Most of the patients that consider this particular act are motivated by the loss of autonomy and dignity and the inability to engage in activities that give their life a true meaning. One thing that I thought was really interesting is that of the people in Oregon between 1998 and 2007, there were 541 prescriptions for lethal doses of medication, and 341 died as a result of taking the medication. 13 patients who had received prescriptions were still alive at the end of 2007, and the rest of those who received prescriptions ultimately died of their underlying disease. About 86% of those patients who had opted to get the prescriptions were enrolled in hospice programs, and 81.5% of those patients had a terminal cancer diagnosis. The Death with Dignity Act outlines a very rigorous process in order to determine the eligibility for anyone applying for assisted dying. You have to make 2 separate requests that are at least 15 days apart to his or her doctor for a lethal dose of the medication. 2 physicians must independently certify a prognosis of death occurring within 6 months and must refer the patient for a psychiatric evaluation if they suspect there's any mental incompetence or the influence of an underlying psychological condition. Also, there is an addendum with some of these states that if they feel like there is a family component to that someone is being unscrupulous and pushing them towards that, then they really want to delve into that as well so that they're comfortable in making that decision. Another thing that I thought was interesting is that patients choosing assisted dying are overwhelmingly white and on average more financially secure and more highly educated than the general population. After 13 years, the number of patients who died from assisted suicides had stabilized at 30 to 50 each year, and they had not made any decisions to broaden the specifications for eligibility requirements or the prescription mechanisms. And Oregon had reported no cases of coerced requests for the medication, so the safeguards as far as the waiting period and the psychiatric evaluation were determined to be well-accepted practices that were in place and working well. As far as pros and cons, and I'm running out of time because this is such an interesting topic, but as far as pros and cons, only a minority of the people who inquire about suicide assistance actually complete the process, and that indicates that the option is actually just perceived as a choice, just like hospice, just like withdrawing supportive care, just like advanced directives, that just gives the patient a little more control over their medical situation that they find themselves in. The decision to provide suicide assistance can't be forced on physicians, and it needs to be left to their individual conscience because obviously it's not going to be for everyone. However, if a physician is prepared to respond to a request for assisted suicide, there are no compelling ethical reasons not to allow the physician to do so, because there's comprehensive monitoring, careful regulation, and an ongoing debate that are required as far as ensuring the physician-assisted suicide is actually a choice based on the relationship between the patients, the families, and the healthcare professionals. It's important that we keep in mind that by offering this option, it can improve their outlook, alleviate their suffering, provide comfort and support to these dying patients. Some patients just wish to proactively shape the end of their life, and to those patients, taking action to end their life is better than passively waiting for death to occur. As far as cons, there are people who take the stance that vulnerable communities in our societies, such as people who are old and frail or disabled or terminally ill, presume or perceive themselves to be threatened, and so physicians have to be extremely careful with those patients. And also there is the thought that it's something like therapeutic homicide. Euthanizing and healing are intrinsically incompatible. The involvement of physicians in such interventions is unethical and harms the fundamental role of the doctor. However, if you look at palliative care, if you look at hospice care, if you look at supportive care and advanced directives, this doesn't look like that much of a new development. It's just a choice that's offered to the families. I, however, struggle with that. I'm not sure that I could discontinue someone's life support in my family, so I don't know that this would be something for me to do. But I do feel like there is a certain need for patients in a terminal condition to have a little bit more control over their situation. If they can be refusing to be intubated or to receive nutrition, I'm not sure that this is that different.